Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs in the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello. Welcome to another episode of the Unreal Results podcast. It's a special one. I have a guest. Many of you know I don't do a whole lot of guest episodes, so when I'm bringing on a guest, it's usually someone I'm feel very comfortable with and I'm friends with, as well as someone I know that is worth sharing and also is going to give you a perspective of how the viscera and the nervous system can relate to musculoskeletal pain, dysfunction, etc. So my guest today is Nicole Cozean. She's a pelvic physical therapist up in Orange County, San Clemente area. And that is the very small part of what she does. So I'm going to let her introduce herself and tell you about all of her things. And then we're going to just kind of riff and just chit chat and let you all hear our conversation.
Yes, this is awesome. Hi, everyone. And Anna, thanks so much for having me. I really appreciate you asking me to be on the podcast. I'm super excited for our conversation. We've had many conversations offline, and I'm super excited for people to hear sort of where we align on a lot of areas. So, like she said, my name is Dr. Nicole Cozean. I'm a pelvic floor physical therapist. I have been a pelvic floor physical therapist most of my physical therapy career. I got roped into doing pelvic floor therapy at a time when it was still considered very weird. I think most of the people coming into it now are so excited about the pelvic floor. Most patients or potential patients have heard about the pelvic floor, but that was not always the case. I remember getting made fun of in my ortho practice quite a bit for taking everyone's pants off. And why is she always going back into that room? And what are you doing back there? And I was like, getting my patients better. Keep up, people, keep up. And so,
On board.
so I have been a pelvic physical therapist for about 20 years now. I worked for and started a hospital-based pelvic floor practice in Orange County, California, at a big hospital-based place. I did that for 5 years, worked for another outpatient pelvic floor therapy clinic for another 5 years, and I've had my clinic for almost over 8 years now. And Pelvic Sanity started back then. It was at a time too where I had written a book called The Interstitial Cystitis Solution. And interstitial cystitis, for those of you who don't know, is a bladder pain condition that I was treating very much orthopedically, fascially, viscerally, pelvic floor wise. And now we know a lot more about that condition, and it makes sense why. So I'm excited to talk to you about those visceral type symptoms and how we can treat those orthopedically. Hello. But so I wrote a book called The Interstitial Cystitis Solution, started Pelvic Sanity. Pelvic Sanity is named very strategically. Everybody thought that it was a dumb name at first. Everyone told me not to name my clinic that. But I was coming home so many times from treating really in-depth chronic pelvic pain patients, and I would come home to Jesse, who's my husband and now business partner, and I would always say to him, "Man, this is just so insane. This is insane that this person had to live with these conditions for so long. This is insane that how much progress we're making in a short period of time." And when we were deciding to name the clinic, we were just like, well, let's just bring some sanity back into the process for patients. And we called the clinic Pelvic Sanity. And since then, we have treated patients from all over Orange County, California, but also all over the world. We have a pretty extensive out of town program. We've seen patients from over like all six continents. So if you know anybody from Antarctica that has pelvic floor dysfunction, let them know that we have an out of town program.
Yeah.
And over like 120 people have come from all over the world. And so really excited to just be able to expand the reach. On that note, I've also created a second company called Pelvic PT Rising, one of the goals of my work at doing the book, which is a patient-centered book on interstitial cystitis, was to help patients to find pelvic floor therapy and go see folks that are doing this. And I got hundreds of emails and communications after people read that book and said, "Well, I went to pelvic floor therapy and it wasn't like anything like how you were describing it should be." And so I took a mission then to not only educate patients on the benefits of pelvic floor therapy, but Pelvic PT Rising is essentially the clinical arm of where I do a lot of teaching, have online courses for pelvic rehab practitioners, and also do business coaching for people that want to start clinics like Pelvic Sanity. So that's me in a nutshell. We've also started a pelvic rehab conference called Pelvicon with my good friend Jessica Rial, which is an in-person conference for pelvic rehab providers. So we're just on a mission to change the way pelvic rehab providers treat the pelvic floor. And I think that, Anna, to your point with all of your work, I feel like when we say we treat from head to toe and we treat the whole person, we actually really mean it.
Yes. Yes. I love
Yeah.
that. You treat the whole organism. And that's
Yes.
why I switched to like saying it that way, because so many practitioners would be like, "Oh, I treat the whole body," because they think, well, oh yeah, if somebody comes in with knee pain, I'm looking at their hip and their core and their breathing, and I'm like, but that's still not the whole body. That's the whole musculoskeletal system. Like, so I was like, this is why when I like I would say that though I don't have the biggest vocabulary, I am very like particular about the words I use. And so that's why I don't say whole body, because of, just like your people were reaching out to you. Like, I've gone to a pelvic floor physical therapist and it's not what you describe. And unfortunately, that's not just pelvic floor physical therapy. That's like all physical therapy. I get so many messages from people that are like, I went to a physical therapist or I went to an athletic trainer and they're like with my knee and they only touched my knee. And I'm like, yeah. And like, I see this across the board at every level. Like my athletes go to other practitioners sometimes that are like well-known practitioners. And it's such a disappointment when I hear what they do. Because I'm like, gosh, like you're even going right to their knee? Like you didn't. And I'm always asking the athlete, I'm like, did they look at anything else? Like, did they even evaluate you? Did they even look at anything? Or they're just like, all right, your knee hurts. Let's do your knee and your hip. And they're
Mhm.
like, yeah, not really. And they're like, definitely not like you, but they didn't really even do anything other than where I told them I heard it. And it's like, damn, like sometimes I feel like we've come so far. And then sometimes I'm like, how are we still here?
Totally.
So, anyways, yes, this is why I call it a whole organism approach as opposed to whole body, because I don't want people to think like, oh, I already do that. I don't need this information. And then I also want people to be like, why is she saying organism over body? Because it has so much more to do with the organism's like fundamental like drive for survival and finding safety in their body and safety in their environment. Like that drives so much. That drives so much, as you know. Like, I mean, and again, like this is like part of the reason I wanted Nicole to come and why Nicole and I have tried to like get to know each other better since we met a while back ago is like because pelvic floor physical therapists, like I end up getting a lot of them in my ecosphere, even though I am not one, because you all like understand that the viscera influences things. And most of the time when somebody's coming to see you, not only do they have like just general musculoskeletal pain in their pelvic area, but they also have very visceral symptoms of stuff. And
Mhm.
so it's like you're already seeing that crossover. So I don't have to spend any time convincing you that it matters. And then, but the other thing, and sort of like, what's my point with this is, um, I don't even know where I'm going with it based on what we were talking about, but it's like, yeah, you already get it. You already understand how, oh, I know how I thought of this is like, So the other thing that you end up dealing with a lot, I would assume, as pelvic floor physical therapists is trauma around this area of the body, and trauma from not just a physical mechanical trauma, but like an emotional trauma, like people who have been, sexually assaulted, or people who have had miscarriages or loss around like births or not being able to get pregnant. Like there's a lot of emotions and fundamental like safety versus survival mode that you deal with on a regular basis, where whether the therapists really realize that or not, right? Like, and I'm sure you talk about that, especially, well, at least the industry talks about that when you're talking about an internal exam. And I know we've talked about a little bit about your training and what your training does, and unfortunately I know it's probably not as like trauma informed and as I would think it should be. But it's like, hopefully it's getting talked to. And I at least know probably the practitioners are aware that when they go in to touch that region, even externally, people who with trauma, like you start seeing it in their body. And so this is too what I mean, whole organism approach, is that understanding that sometimes even just to do a good evaluation on someone, it's not about the questions you ask. It's not about like anything other than like setting the tone to have the environment in the treatment room, or then the co-regulation already starting just when you're talking to them, just when you're welcoming them in the door, how you sit next to them, like paying attention to their body language and understanding that you could literally be the best pelvic floor physical therapist of all time, do the best internal work, like learn from the best, do the best, like have the best hands-on. And if you're not paying attention to what their nervous system cues are giving you, you're not going to have good treatment outcome, period. Because they're never going to feel safe enough to elicit a healing response, because healing happens in a safe nervous system. And so if they spend their whole appointment with you is still in this like fight or flight survival mode, then it doesn't matter how good of a technique you did, whether, because you're not doing it where the body needed it. And the body needed the first technique not to be in the pelvis, but the first technique to maybe be up in their cranium, away from them, to sort of like tap into their parasympathetic response to decrease overall central nervous system tension from feeling threatened, before you can go in there. So anyways, that's a little bit too of like why I say whole organism
Yes.
versus whole
Whole
body.
body.
And I know you appreciate that too, right? And I know that when you're teaching practitioners with your how to have a practice like pelvic sanity, when you're talking about whole body, you're talking about whole organism.
I am talking about whole
Yeah.
organism, and I love that distinction, and there is a difference, with talking about it like that. And so a couple things I wanna pull out from there too is, so I love when you say, like, we have to take the whole patient experience
Yes.
and make it safe from the beginning. And we'll
Yes.
go into why that even matters even more from a
Yeah.
pelvic floor perspective, but it matters for everybody as well. And so, and I think that, so we are very specific of, what pictures people show on the website, like how we're interacting with them on the phone, what the waiting environment is like. Even something so as simple as teaching our front desk staff to say you can either have a seat or stand over here. Because if you tell somebody that they have to sit down socially, that can create anxiety if somebody is literally coming for pain with sitting.
Yeah.
And so, it's like now all of a sudden they're thinking, well, if they don't, why are they going to make me sit? I don't want to sit. I don't want to get worse. Like, do they even that?
Yeah.
Then they go immediately to the catastrophization of that, which, like, am I even in the right place?
Yeah. Do they
Are
even
they even going to know
understand
what's
me?
going on?
Mhm.
Yeah, and so I feel like the empathy that we have to have for folks that are actually walking into our doors needs to extend into every aspect of our being. How are we walking them down the hallway? Where are we telling them to sit? Can we give them a moment? Um, and pretend to go get a pen just so that they can scan the environment without you being in there.
Yeah.
You know, and it, one of my mentors talked to me and said, like, pretend you don't know anything about
Yeah.
pelvic floor or what's going on. You go into a treatment room, you walk in, and there's literally at least 3, probably, if not 4 places to sit. There's the chair that we all assume that they're gonna sit in.
Yeah.
There's the stool that we sit on. If you have a desk in there or another chair somewhere, there's that, and then there's the treatment table.
Yeah.
So even just that, even just helping them to know, like, telling them what to do, having them take a half a beat, by telling them to sit not on the table, now all of a sudden they know we're not going to start with the internal stuff. We're
Right.
going to talk first. You can do all that stuff without saying a word,
Yeah.
right? And so that's where I really feel like the patient experience helps to create safety from the very beginning, and that's something that we take a ton of importance in, and we place a lot of importance on that at Public Sanity and everybody that we teach. And then the other thing that I wanted to point out too from your just what you were saying about the whole organism is that I really I always tell people that I'm teaching and training, we have to remember that at the point when somebody, in this case specifically, has a pelvic floor problem, they have a pelvic floor symptom. That means they have something that your body is now no longer able to compensate for. We can go a lot, and a lot of time, a lot of things can happen where our body is innately prioritizing peeing, pooping, sexual activity, and protecting that region at all costs. And because those are such fundamental bodily functions for our physical survival.
Yeah.
And so at the point when our patients come in and they have something that is going awry with one of those things that your body is innately neurologically designed to protect, shit's more jacked up than we realized. You know what I mean?
Yeah.
And it's because the compensatory strategies are now also no longer working.
Yeah.
And so I think that to understand that, even though something like stress incontinence is quote unquote simple, and I'm using air quotes,
Yeah.
um, it's a relatively simple thing that's happening, right? There's a pressure that is greater in the bladder than the pressure of your urethral sphincters can connect and prevent. Like, it's literally can be whittled down to that. Anatomically, that's what's happening. But the reason why that's happening is so much more complex than that.
Yeah.
And it means that there has been a loss of protection, a loss of that compensatory strategy to protect the very region that we're neurologically designed to protect at all costs. And so I
Yeah.
feel like if we think about that, then we have to have a bigger reverence for the patient sitting in front of us. Because even the symptom that they're describing may seem benign or not that big of a deal to us as practitioners, but it's a freaking big deal to the patient. And it's a really big deal that the body has now come to this place where it's not able to compensate anymore.
Yeah. So good. And actually listen to you, I'm like, you know what? Maybe I should reorganize a little bit of the steps of the LTAP. Because so it's like one of the in the LTAP, and you've taken it, so like one of
Yeah.
the things is like it's set up based on an organ hierarchy that is kind of made up. Like it's not like they teach that in the Brawl Institute. It's like made up for me because I had to organize things in my brain of like proving that my listening skills that I learned with the Brawl Institute, like I was seeing a pattern of them. And so it made me kind of go back and be like, can I kind of mimic this pattern when I'm choosing these orthopedic tests to get us arrive us at the same spot where the body's protecting. And the organ hierarchy was like basically like look at the structure of the body, and the organs that it protects in hard frames are more important than the organs it doesn't. And I kind of have always lumped the pelvic organs with the abdominal organs because it was just convenient. But I kind of like from listening to that, I'm like, God damn, you're right. Like eliminating our waste is like you can't survive without that. You can only go so long without being able to eliminate your waste. And so it's
Mhm.
like, perhaps the pelvic, I mean, and I say that too when I teach it. I'm like, yeah, and the organs in the pelvis, they're more important probably than the organs exposed in the thing. But yet my LTAP doesn't reflect that. So I'm like, might be
Maybe it's
changing that.
a subcategory,
Yeah,
for instance.
subcategory. I might be reorganizing things and be like, no, we should probably check the bladder and the um reproductive organs and the rectum first.
Potentially.
Yeah,
Yeah.
before and like maybe include them a subset of like, because like the thoracic cavity first is the cranium, second is thoracic cavities above the diaphragm, actual thoracic cavity. Third is thoracic abdominal organs, so like liver, pancreas, spleen, stomach. And then I'm like, oh, and the abdominal pelvic organs. But I think that the bladder, the uterus, ovaries, and um,
Rectum,
rectum, seminal vesicle, they all need to probably go with the
prostate.
abdominal thoracic organs
Yeah, yeah,
because
yeah.
they're also in a hard frame.
Yeah, totally. And procreation. I mean, if you really
Yeah,
think to what the species
yeah,
survival based on,
exactly.
like, so if you even go more meta, then
Yeah,
it's that too.
yeah,
Um, so yeah, and again, I just really think that we have to have reverence for our patients too, of people that have this stuff, even if they're not acting like it's as big of a deal. They can be super
huge
excited to
deal.
see us,
Yeah,
you
yeah,
know? And but then when we actually get down to it, and I love when you're talking about like when we're actually touching people's bodies in even in the abdomen, right?
yeah,
Even in the abdomen. I always tell my staff too when we're doing some training, I'm like, pay attention not to what they say necessarily, but what their body's doing.
yes,
So even something as simple as if your patient is supine on the table and they have their legs crossed,
yes,
that's a very
close.
closed
Yes. Mhm.
posture. And you might ask them, "Are you comfortable? Do you need a wedge
Yeah,
underneath your knees?" And they'll be like, "No, I'm fine,"
yeah,
because they're people pleasing. They may
yeah.
be in a sympathetic state that is actually, or
Mhm.
ventrovagal state that is like more of like just, "Oh, it's okay, everything's fine,"
Yeah,
right? But like, just instead, could we not say like, "Hey, I'm just
just
gonna
put
put
it
a
in there.
pillow underneath your
Exactly.
legs because I need symmetry when I'm as close to symmetry as we're starting when I'm doing evaluation, because them crossing their legs, number one, means that they're closed off. They might not be as comfortable as they're saying,
Yeah.
but then also that can change my
Yeah, assessment.
exam if
Mhm.
their right leg's crossed over their left or their left leg's crossed over their right. Like that matters.
Yeah.
And so I really love that you're that specific, because this is why I love you.
Yeah.
It's like,
Yeah.
yes, we're that specific. Yes, we think about this stuff.
And we're
Um,
always observing and we're observing for cues of safety or threat. And I'm like, yeah, when you go right before you go to put your hands on somebody, or even after you put your hands on somebody, you should be looking at their face
hmm,
as well as their whole body, but definitely their face. like,
yes,
like you want to make eye contact with them, but also not even eye contact. You want to be observing their face to make sure that they feel safe, because
totally.
like the first place they're going to show you they don't feel safe is their face, whether you really recognize it or
Yeah, and
not.
their eyes and like, and then even if I know that I'm gonna, I don't know, assess the urachus for as an
Yeah.
example or
Yeah.
something, like I still am not gonna go right to that area as excited as I am as the
Yeah.
practitioner to see.
Yeah. Yeah.
Is this gonna elicit a bladder response if we go up near their belly button?
Yeah.
Ooh. I feel like we can get so excited, and I sometimes it's just a hand resting on the outside
Mhm.
of their, of the towel or the gown or whatever you got going on with your situation, a hand resting on their pelvis for a second as I'm talking, as I'm going to explain what I'm going to do. Then I ask a question, may I lift up this
Yeah.
area? I'm going to place my hands on your abdomen. Like you're narrating what you're going to do.
Mhm.
Because even your words can elicit
Yeah.
a threat response, your touch, like all of that.
Everything.
And so yeah, and sometimes we can listen to the body and wait for it to settle for a second
Mhm.
to see, like, because it does do a little bit of an assessment too. It might be initially like, uh-oh, and then be like, no,
Yeah.
she's okay,
Yeah.
she's safe.
Yeah,
you
it's
know?
okay.
So it
Yeah.
give them a half a beat to figure out
Yeah.
what's going on, and then that can become and I always too, I go even if I'm gonna work on a different area of the body, I will
Yeah.
sometimes always create what people can expect. So
Yeah.
every single time someone lays supine, I'm gonna do that same thing,
Mhm.
and then we can go wherever we need to go, but now it's like a starts to be a treatment pattern that the body learns to expect, so it's not so surprising if we do something different.
Yeah, exactly. Yeah, I was just this past weekend I was teaching an LTAP course and I was like telling, after you watch everybody in a breakout lab, you're like, "Oh, okay, I need to emphasize this." And so I was like, one of the things I emphasize, especially when you like as the practitioner, when you don't feel super comfortable about a new technique you're trying, I'm like, don't be in such a hurry. Like, be patient. Like, just be patient. You have you I mean, it's like that with any sort of relationship with somebody, right? Like, nobody likes franticness.
Right.
Especially when it comes to touch. It feels very uncomfortable, and so it's like, just be patient, be soft with your hands, like, let them be there for a second and let them get used to that, and
Mhm.
let their body respond, and then go into the task.
Yeah. I
But if
always
you
talk
go in, like, all fast and quick and, like, "I'm not sure what I'm supposed to feel," and you have all this tension, it's like, they're gonna feel it too.
Yeah.
And the thing too with the pillows that I like, I talk to people about this all the time, like, yeah, I don't when I am looking for an answer, I'm not looking for words. I'm looking for your body to tell me. And so it's like, if I feel that maybe you would be more comfortable with a pillow, instead of even asking you, I'm just sliding a pillow under your legs and looking at your response. Most of the time, I'm right. You needed a pillow. And then I don't even have to worry then about them trying to be like a people pleaser and be like, "I'm fine." And I'm like, "No, your body's telling me you're not fine." Like, I appreciate that you don't wanna be an inconvenience, but, like,
Right. But
you're
also
fine. Right, and so I'm like, "I'm just gonna put some pillows until I see your body do a certain thing, and then
yeah,
I'm gonna point it out. See how much more relaxed your body is? Isn't that nice? Like, let's just make sure that we always have these sort of little props for you so your body always feels comfortable." Like,
totally.
these
Absolutely.
are
And I
these are these are specific for your body only. Not this is not everybody gets it. And then they feel like, wow, like this is kind of special. So I
yeah,
mean, I know me and you could probably write a entire like do a whole weekend workshop on like this,
just on that. Yes.
just on this, which is like
1000%.
crazy because it's so needed. But I feel like nobody would take it because they think
I
it's
know,
like,
because no one thinks that they need it, which is why this podcast is gonna be right. We gotta give them what is that phrase? Give them what they
yeah, meet what they want
want,
with what they need.
what they
Yep,
need.
and
Yeah.
marry the two.
And I also wanted to point out that you also said something really interesting about, being in the pelvic floor space and trauma. And I've read a couple different books, um, a lot of books on this actually, but one I'm reading right now talks about the, we all say it in like big T and little t trauma. I feel like the overt, obvious traumas to the pelvic region or things like sexual assault or even just being in an accident or some sort of major blow to that region.
Yeah,
Fall on a tailbone even can be considered that.
yeah, like an acquired
Um,
trauma.
so I feel like those are like direct traumas to that
Mhm.
region. Some more emotionally involved than others, but there's also the little t trauma essentially that where because it's where you hold your anxieties as
Yeah.
well. And
Mhm.
so an event that, wouldn't be quote unquote traumatic to anybody else, um, even something like it from your childhood, like getting made fun of
Yeah.
or something like that, like where was that held?
Yeah.
And I do believe that there is that different people hold stuff in different areas of their body.
Mhm.
And I think that as a pelvic floor therapist, we tend to see a lot of people that hold tension in their pelvis, but not everybody holds their tension there.
Yeah.
And sometimes like if you're getting scared during a movie, what happens? There's actually an article that looked at pelvic floor muscle activity um with
Scary
scary
movie.
movies, and a
Okay.
lot of times people with pelvic floor dysfunction would
Yeah.
have that, greater, reaction at their
Yeah.
pelvis, but some people can do it in their throat, in their chest,
Yeah.
and I feel like whether you're someone that doesn't treat into the pelvis that much at all or someone you're listening as a pelvic floor therapist that does, I do feel like we have to understand that our patients may have a greater tendency to hold tension in the pelvic region than we might realize or that they might realize. And
Mhm.
that's the thing. They can say, "Oh, I'm fine. I'm really high achiever. I don't really get anxious that much." And even their stress response on a day-to-day basis when they have 3 kids and they're running around and doing all the things and they're a lawyer also, and now all of a sudden it's like, "Well, right, but you're holding tension there
Yeah.
still out of a protect zone for that region." And so yes, that doesn't count as like trauma as it's
Right.
defined in like the textbooks, but it can be a repetitive holding pattern
Yeah.
that's meant to protect. And I feel
Mhm.
like that's something else to realize that a lot of our people that are having these issues at the visceral level when they see us also have those tension patterns that are being held from other areas of
Mhm.
their life.
Absolutely.
Yeah.
Yeah. I see it too.
So let's talk too, because I did take the LTAP, Anna. As
Yeah.
you know, it's one of
Yes.
my most favorite courses I've ever taken. You know what? I'll
Oh,
say this too, and
I didn't even pay her to say that. I love that.
I know, but here's the thing: I feel like when I told some of my colleagues that I was taking it, they're like, "Oh, who is this chick? Oh, she's just an athletic trainer."
Ah, yes.
I'm sure you get that a ton. So what do you what do you say to that? I'll tell you what I said to that, but
Yeah. Well, so yeah, so I guess I get it more from people who are I probably hear it obviously people who come to my classes like they think I'm amazing. Like this is the funny thing about like somebody was like, "Are you nervous for teaching this weekend?" I was like, "No, no,
these are my
literally all
people.
of
Yeah.
these people they're my people." Like there's probably nothing I could say this weekend that would make these people not like me. I was like there's like maybe 2 people in the class that don't really know me and maybe won't like me by the end. I was like, but I'm pretty sure they'll like me. I'm pretty sure they'll be on board like the rest of the people, and they're just the people who were like free spots for hosting the course, right?
Right. Right.
Um, but I was like, yeah, no, everybody else is like my biggest fan. They're like, this is of all the things that I do in the world, this is should come with the least amount of fear because they already are bought in. I was like, so the just an athletic trainer, I get that mostly when I'm attending other continuing education courses.
Mm.
And or I get that when somebody has heard me speak or heard me describe something and they're like, "Wait, but you're just an athletic trainer?" Or I'll get like, "Wow, you know a lot for an athletic trainer." And I always laugh because I'm always cuz and so it depends on how like confident I'm feeling in that day cuz sometimes I'll be like, "Actually, I know a lot for everyone."
Yeah.
I'm really smart.
I'm
In case you
actually
didn't
really
realize
smart.
it. Right. And obviously, as I've gotten older, my response to that comment has changed over the years. At the
Mhm.
beginning, I tried not to be offended by it. And then there was a little while that I was offended by it and didn't say anything. And now I'm not offended by it, but I also will be like, yeah, yeah, I'm really smart. It's not, I'm like, I could be a bitch and be like, you're just a physical therapist.
Yeah.
Like,
I
or
know.
like, you're a physical therapist and you don't know this. Like, you know what I
Right.
mean? Like,
Totally.
there is and this too probably is why I let all practitioners come to my courses, not just PTs, not just athletic trainers, because I 100% have seen in my whole career in Con Ed classes, in places that my athletes have gone for physical therapy or athletic training, like it doesn't matter what your credentials are. There's a lot of shitty practitioners out there, period. Both physical therapists, athletic trainers, chiropractors, doctors, Pilates instructors, like there's a lot of fucking shit out there.
Yes.
A lot of shit. And also, there's a handful of great people in all of those fields.
Mhm.
And the thing that makes them great is not their credential.
Totally.
Period. And so I'm like, you know, for a while, we get really like I think people get really attached to their credentials because they worked hard to get them and earn them, and I can appreciate that. But also, like when somebody is so attached to that or like is threatened by that, I'm like, you have a lot of work to do like, there's a bigger block become between you getting better and doing better for your patients than you probably realize, because the fact that you even think that it's a problem that I'm just an athletic trainer and have nothing to teach you means that you're not open to learning things, and you're not open to learning things outside of, like, traditional ways of doing things, and so, this is probably not the right course for you anyways,
Right.
you know? So
1,000%.
I'm like, nowadays, I don't take offense to it, I just take a mental note of like, you're pretty closed off,
Yeah,
so, yeah.
fully. But I mean, I absolutely so for those of you who are thinking about maybe taking it, I feel like definitely like do it. But here's the thing. What one of the amazing things about the course that I really loved that I think that everybody should think about is and it really like leveled the playing field with everybody is when you went over those core beliefs and like kind of like the things that we are going to go into this weekend assuming at first and then basically proving by the end of the weekend.
Yeah.
And I've actually stolen that in my thought process a little bit like in some of my teaching because I feel like it's so awesome to think about what are all the things that we're going to agree on if this stuff is going to have its optimal um you know, go optimally go into your brain, right?
Right.
Because I feel like and I usually call this "yeah, butting," where people are like, "Well, yeah, but," where you
Yeah.
people get defensive,
Mhm.
regardless of
Really?
what,
Yeah.
what their credentials are or whatever. It's I feel like it's a little bit of a human nature, and it's a freaking pet peeve of mine of people
Mhm.
that do "yeah, butting." I think I did a whole podcast episode on my podcast about people that "yeah, but." It gets me fucking annoyed. But I really but I
But
feel
yeah,
like
but
I feel like this amazing thing that you did really helped everybody to sort of be on the same page going into what you were
Mhm.
teaching and how you were teaching it. Um, and one of those core beliefs was this thing that we were talking about at the beginning was this that there is in fact a hierarchy to what your body is protecting
Yeah.
period and I feel like we all understand this innately as human beings, but I feel like sometimes we forget it when we put ourselves into the practitioner role
Mhm.
and we're just so obsessed about fixing the thing that the patient is saying is wrong.
Yeah.
And I say this in my teaching is like, "Oh, find the why and keep asking the question, well, why is that like that? Well, why is that like that? And why is that like that?" But I really loved how you sort of laid out at the beginning the core beliefs, things that we're all of us in this room are essentially making a pact
Yeah. Support.
to
Mhm.
support.
Yeah.
Yeah. And then now we're going to
Agree.
move into the weekend with these core beliefs at the core of what we're
Yeah.
doing today. And then we can now work off of that. And that I feel like that was a really great thing, especially when you have multiple different people from multiple different backgrounds in your
Right.
courses. Because I think that that can enhance the experience, and I feel like you
Mhm.
helped everybody to really get on the same page, and I
Yeah.
really appreciated that.
Yeah, no, it is. I have liked adding that in. I actually got it from Jill Coleman. It's like
Oh, cool.
a sales it's like a sales strategy.
Interesting.
Really, is to, like, identify the core belief of each offer, and, like, basically that's what you're trying to prove to them, like, that you have the answers for. But also, so what it is to me when I heard it and when I why I am like, "Oh, I love this," and I'm gonna because a little bit of from a sales strategy, you don't, like, necessarily call it a core belief right at the big, but you, like, basically, like, that's how it's set up. Um but I was like, I'm actually going to just call it out and be like, these are the core beliefs of each one of these courses. One, to organize my brain, but then also because I'm like going back to like fifth grade science project, right? Like it's the scientific process.
Method. Yes.
It is the scientific method to have a hypothesis and then spend your whole time trying to prove or disprove the hypothesis. Like that
Yes.
is the whole scientific model that all sciences are based off of. And so that's why I think it's so important too to identify like this is the scientific model that we're going like that we're basing everything off of. And then you're the scientist. It's your job to really the way the scientific method is set up is like you're supposed to disprove it.
Right.
And if you can't disprove it, then it's like a valid method.
Right. Yeah, yeah, yeah.
Right.
So it's
Yeah.
so funny. And this is like convergent evolution as at its finest. So I have a course called Pelvic PT Essentials. And essentially it's the how to, like when people take their first pelvic floor course, then they're
Mhm.
left kind of like, I'm supposed to actually treat a patient. Like,
Right.
what the hell? I just learned how to stick someone with my finger in someone's vagina. And now I
Now
don't
you
know
want
what
me
to
to
do.
put it
Right.
in
And
as an actual
I
treatment?
teach we call it in the essentials, we call it having a prior. Like you have to have a prior assumption of what you're looking for to happen when you do
Yeah.
said intervention. And then if it doesn't happen, then it's like, it should create pause, or what else
Yeah.
am I missing? Or
Yeah.
what else would make sense when that's the outcome?
Yeah.
What else could be behind? What are the
Right. And
steps up
so
there?
what's happened, and this is the whole thing, is like somehow our industry got so hooked on being the expert, got so hooked on the credentials, got so hooked on like solving everyone's problem that they forgot their main hat was a curious scientist. And the
Yes.
curiosity is then completely lost. And what happens when we lose curiosity is we stop reassessing and we stop looking at even how our intervention changed things in the body, not an intervention from like they came in week 1 and by week 8 they are better. No, 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 no. Like in terms of like this was my assessment, I did this thing and then I instantly reassessed and what changed. And did what change? Did I expect it based on my hypothesis? Does that make sense based on the like hypothesis I'm going from that like is going to make sense of their pain, or does it not make sense? And whether it does or doesn't nothing is nothing to do with being right or wrong. It's
Mm.
more information,
Yes.
and more information should breed more curiosity, should breed more possibilities to help someone fully, as
Yes.
opposed, and this is a thing, like so many times. Well, and we're doing this whether we realize it or not. Like we're basing all the information we're gathering, we're trying to prove our points, right? And so it's like, but it's always proving whatever bias you have. And so this is again goes back to why it's nice to list out those core beliefs, because it's like we're believing that we're believing that the breath hold is influencing things from a neurological standpoint, a sensory standpoint, not a pressure. Well, yes, a pressure standpoint, but pressure as a sensory experience that the organs are having, which is better information to the brain, which means better output from a output standpoint. And the outputs we're looking at are mobility, strength,
Right.
range of motion. I don't know, like motor performance, that kind of
Yes.
thing, right?
Yes. 1,000%.
So
So that is freaking brilliant. And I just loved that whole thing. The other thing that I feel like I get a ton, and has gone into my teaching, but that when I was in the course, I was like, yes, like, someone could be sitting in your class or even some of my courses and being like, but what's the evidence for that? Right?
yeah,
What's the evidence for that? So,
yeah. The old
is
evidence-based practice trolls.
yes, I call them the evidence police. All right. So, and I understand the need and the want to quote unquote practice evidence-based medicine. But one of the wonderful things I loved about having the core beliefs and then having, your brain help us to process stuff and what we're seeing
Yeah,
in the body and all that kind of stuff, really at the end of the day comes back to something that I truly believe and that I put in my teaching too, is that like anatomy is evidence.
yes. And the patient in
Physiology
front of you is
is
evidence.
evidence. Patient in front of you is evidence. And like,
That's what I think makes me so frustrated, is because I'm like, at the evidence-based police people, I want to know how many times they're actually reevaluating their patients within their session, because I don't think they are at all.
no, I mean, no, I would challenge that too. It's just
Yeah,
like,
because I'm like, that's the evidence. There's evidence right there.
mhm.
There's evidence right there.
And for instance, even for something like the bladder, right? It's like, why are you working there? What's the evidence for that? It's like, it's fucking anatomy. It's that the the autonomic innervation of
Yeah.
the bladder comes from T10 to L1
Yeah.
and S2 to the S4. Like,
Yeah.
you have evidence to be
Yeah.
working at the sacrum and the lumbo,
Mhm.
uh, the thoracolumbar
Yeah.
junction for your people with bladder pain. You have it.
100%.
You also have it for the peripheral nerves that go there. You have it for the dura that
Yeah.
goes right through there. You have
100%.
it to be there.
Yeah.
You have
The
going
better
all
you
the way up
know
to
the
the
anatomy,
cranium.
the more evidence you have.
Yes.
And that to me too is like when people are like, "Where the evidence?" I'm like, "Oh, tell me you don't know anatomy without telling me you don't
Right.
know anatomy."
Right.
If you're asking
Totally.
me for evidence, you're clearly telling me you don't understand all the layers of anatomy.
Yes. And then also the physiological system. It's like, well, why are you
Yeah.
working at the groin to help with, prolapse symptoms? It's like, because pressure, like, the organs don't, by design, they don't they give a ton of information, but stuff that doesn't always reach our
Yeah.
consciousness, right?
Yeah.
And so if there's something in our organ systems that like pressure in the pelvis, it can also be from things like inflammation. And do I want to work on the lymphatic system?
Yeah.
Hell yeah. And
Yeah.
it's like, it just because the person's feeling pressure doesn't mean they have a prolapse. Even if they do have a prolapse, does it mean that that's the problem? Is that why they're sensing
Right.
pressure?
Yeah.
No. And
Yeah.
so there's just so
I'm like,
many other
well,
physiological systems that we need to consider that can create those inputs to the organ that's going up to the brain, and that is your evidence to treat that
mhm.
region or that body system.
Yeah.
It doesn't have to be that somebody has researched this exact groin technique,
Yeah.
or even lymphatic
Right.
drainage for
Yeah.
prolapse symptoms. It doesn't have to be like that. It can just
Yeah.
be that we know that major lymphatic drainage happens at that region, and it can be disrupted, and that can create pressure. Like,
Yeah.
period. End of
Well,
story.
and then like too, like those organs in the pelvis are endocrine organs. And so like
Yes.
that means they work in a system with all of the endocrine organs. So you can have something affecting the thyroid in your neck. Pressure, like you can have like shit going on in your neck that is affecting the thyroid mechanically that is going to influence the uterus and the
Yes.
ovaries.
And the
Like
hormone system and all of that.
I'm
Yes.
like, come on.
Come
Like
on.
this is again, like show me someone who is like, tell me that evidence is means somebody doesn't understand anatomy and physiology as well as you would hope they
You would
would.
hope they would, right,
Mhm.
totally. But that's I feel like that was one of my biggest, just, again, like, solidifying moments, that not only, I mean, it was a huge challenge for me to be like, "Gosh, I feel like I know anatomy a lot," and you
Yeah.
still freaking blew
Yeah.
me away with some of this stuff. I'm
Yeah.
like, "Well, that goes where?" I need to, like, look at pull out my
I mean,
netter and be like, "What the hell?"
I knew I had a lot of pelvic floor people in the class, so I, studied up a little bit before class to be like, how can I point out and it wasn't necessarily to like impress you all, but it was to show it's a demonstration sometimes to show people that if you think you know the anatomy, there's still more to learn.
Absolutely. And then the other thing is like, for anyone listening too, like, when I treat patients, I keep a freaking anatomy book
Yeah. Oh,
right
100%.
there.
I
Like,
am constantly Googling pictures, or I have them
yes,
involved. I say, "Hey, will you grab your phone and will you
look
Google
up.
the ovary suspensory ligament for me
Yeah.
so I can see a picture of it?" And they're like, "Sure." And then they're participating and
Yes,
helping me out.
totally. And then I feel like that is it's powerful for the patient. They start to look at stuff. Then our brains, our clinician brain can start to be like,
Yeah,
where
it
is
informs
that?
your hands.
Yes, all of it. And so I
Yeah.
just really feel like, for anybody thinking like, "Oh my gosh, they know so much stuff," especially Anna and all the things, it's like, I still have cheat sheets
Yeah.
everywhere, all
Same.
over the place. I
Same.
mean, of all of the viscerosomatic reflex
Yep.
connections and the innervations of all of the different things, like, it's okay to have that because we can't be expected to remember and know every single
No.
thing.
No.
But what we can be expected to do is make sure that we are treating in a
Sharing.
way that makes sense for how the
Mhm.
patient is presenting in front of you. And so sometimes we need a little refresher on what else could be a pain generator in that region,
Yeah.
or why else is that pain not going away because I thought that this intervention was going to be the key, and
Yeah.
it's not. So what does that mean? Where else can it be coming from? And
Yeah.
sometimes you can like look at stuff and just be like,
Mhm.
oh, I didn't remember that the broad ligament goes right over the iliacus, and like where does that get innervated from, and all of those different things. Like we got to make sure that we're looking at the totality of the area in front of us as well.
Yeah. Yeah. I agree. And as we're like talking about this, one of the things too that I say at the beginning of the course, and this might this even goes back to your question about like what do I say when people are like, oh, you're just an athletic trainer, and I'm like, when people are saying saying things like that, it's actually them being offended. And I tell people at the beginning of the class, like I tell this story about how my first Barral class, like they said how Jean-Pierre Barral says that the muscles are the garbage can of the body because they're like basically just like protecting everything else, right? And they absorb a lot of tension and adhesions and stuff because of that. And so there's a lot of junk in the muscles because they're being a bodyguard. And but it was also like interpreted in my brain that bodies are the garbage can, meaning they don't matter, because I think of garbage as being wasteful. They don't really matter. And it took me a couple weeks after that course to realize like how deeply offended I was by that comment.
Mm.
Because that comment in like one fun, the teacher I'm sure was trying to be funny too, right? Like he was like, oh, Jean-Pierre says the muscles are the garbage can of the body. And everybody kind of laughed, and I laughed, like I was like, oh yeah, it was funny. But like weeks later, I was like, fuck, that really offended me, because my whole career up until that point was centered around the musculoskeletal system being like, this is the thing I've been studying for, at the time it was like 10, 12 years, right? And so I was like, I didn't realize how much it offended me. But that I was smart enough to realize that being offended like that was challenging some deeply held beliefs I had about the body,
Mm-hmm.
and was challenging this hypothesis I had about the body. And so I was starting to then have an experience to prove my hypothesis was wrong. And so that's the most important thing. So it's like sometimes too, fundamentally, like people thinking she's just an athletic trainer, it's like challenging a deeply held belief they have about how they know more than athletic trainers,
Yeah.
or athletic trainers shouldn't know that, right? But then too, like it's also when I do the core beliefs at the beginning of the class to sort of set the tone and um, put us all in a scientific inquiry process, and to like let everybody know that we're all on the same playing field now, regardless of our credentials. I also say, hey, disclaimer, this weekend I'm going to offend you. In fact, not only am I going, like, not even disclaimer in case it happens, like, I didn't do my job correctly as a teacher if I didn't offend you and didn't challenge deeply held beliefs you had about the body. And if I don't offend you and I don't challenge those deeply held beliefs, then you're probably not going to walk away from this weekend like actually making a change.
Totally.
And which is fine, because sometimes you're not ready for that. I'm like, but also like that means when I challenge deeply held beliefs, there's going to be a lot of cognitive dissonance that comes up, and it feels icky. I was
Yes.
like, and I saw it this weekend, like everybody's all super excited Saturday morning, and then by lunchtime people are like, either they're like, fuck this,
Right. Or
or they're like, I
questioning.
don't believe, they're like, I don't belong here. I'm so lost. Like, this is all new to me. And then by the end of the day, they're like, brains are fried. They're questioning everything they've ever done. They're like beginning to see, like, they're beginning to feel that cognitive dissonance of me challenging the deeply held belief that everything they've done up until this point was with the wrong lens of view.
Right.
Or not, I don't want to say wrong. Wrong's a harsh word. An incomplete lens of
Incomplete.
view.
I like that's a better way to put
Yeah.
it, but also wrong.
And
I'm just kidding.
also wrong. But also wrong and incomplete and wrong. Because it's incomplete, it is wrong. But and so it's like, yeah, by the end of the day, like I can see it. People are like just having that internal battle with themselves.
Mhm.
And, luckily by the end of Sunday, everybody feels much better and like capable and like inspired by it. But I'm like, I warn people Saturday morning because I'm like, and maybe you've never felt that in a course before, because honestly, I took like 10 Con Ed courses a year leading up until I started taking Barral Institute classes, and I never once felt offended.
Yes, absolutely. And I feel like that's a sign of learning and growth. And when were things, even when I was in your class, when I was like, well, of course she's going to say that because she's done so many other brawl things. Well, of
Yeah.
course, and be like, well, how am I going to ever be able to do that, when
Right.
she's looking at it through a lens that also includes blah, 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 blah.
Right.
And I've only taken, 3 visceral courses, and
Right.
so I just I feel like, but that was a good feeling for me because it's like, no, wait a second, I can do this. And it's
Sure.
good for me to feel like that as well. And I loved being the participant because I'm so often, I mean, you can drink your own Kool-Aid
Yeah.
for a long time. So it's like you always have to challenge yourself to get challenged. You know what I
Yeah.
mean? And especially as like a course creator and stuff, like I feel like that's really important. Um, to take
Yeah,
other
and it doesn't
people's
feel
stuff
good.
and
Yeah.
challenge your own things and like where do I agree? Where have I, disagreed at any point?
Yeah.
Where do I need to shift? Like you're even just talking about shifting potentially a little bit of the
Yeah. I'm
subtype
like,
of the LTAP. It's like
I'm not even talking about it. I'm gonna have to.
yeah,
Like
it's
I'm
like
having these realizations. I'm like, well, I can't keep going on the way I've been going.
right. Right. So, and I feel like I just love that type of growth mentality too. And I think that, for anyone listening too, it's just like, where can you be seeking out that growth from somebody else and challenging something? And I hope that I do that for people too.
Yeah.
I hope that someone sat in one of my courses and been like, I don't think that that's going to work, or I don't think that I can give a supplement recommendation because blah, blah, blah. And it's like, you're challenging those things about, um, the way that you practice. And that's the
Yeah.
only way that we get better.
Yeah. 100%. Well, and I think too, so one of the things you said is like, how can this be true for you when I have, like I've taken 20 Barral courses. So yeah, I've got a lot of techniques and information. And one of the core beliefs that we do lay out in the LTAP, which is a big core belief, is that it doesn't matter what tool you use as long as you're in the right spot. And
Yeah.
you're in that. That's another quote actually from Jean Pierre, is like, you can use the best, you can perform the best technique on the obturator externus or internus that you want. Like you can literally could have written the book on it. But if it's not where the body needs the treatment, if it's not where the body's protecting, then it's not that great. It's not, you're gonna not gonna have a very good outcome. And I could do, if the body is like actually taking me to somewhere in the thoracic spine, and I do a technique around the thoracic spine first, and it can be a general and it can be a movement. It doesn't even have to be a manual therapy technique. It can be like laying on the quarters while breathing, or it can be like just seated rotation in the like very specific to the right segment. If I start there and that's where the body's protecting, then I'm going to have a better outcome for my patient, right?
Right.
Because I'm following the body. I'm meeting the body where it's at. I'm not forcing the body. And so that's too. And it kind of makes me laugh with the Barral Institute. Obviously, I love them and I love their classes, but they're, you're always like thinking about like what people are saying and then what their actions are, right?
Mhm.
And any, not even Barral Institute, just in general, like it's sort of like I always go back to relationships. We've all probably been in a relationship where the guy or the girl says all the right things, but if you really look at their actions, they're
They're not
like,
calling you back. They're ghosting you on text.
your friends are like, they don't really like you,
Yeah.
but you're like, but they tell me how great I am. They tell me they like me, but they don't show me they like me, right?
Right.
And so this is actually the funny thing with the Barral Institute. They tell us from the very beginning how important assessment is, but then all of their courses are actually focused around techniques, treatment techniques,
Right.
very specific techniques on very specific pieces of anatomy. Well, I'd say the other thing it's focused around is learning the anatomy. And they do say that's a priority. So that matches up. They talk about how important knowing the anatomy is. They teach a lot of really great anatomy. But then they talk about how important the assessment is, and they teach it once and they reiterate it, but then they never really go back to it. And they assess the individual organs and the mobility of the organ, and that's important, but less important than the actual general assessment of like figuring out where to go. And that's like they're always, even the teachers, when you ask them a clinical question, most of the teachers will be like, well, where was their general listening taking you? Where was their local listening taking you? Right? They'll ask, like, did you do that general assessment? And but they, since they don't ever revisit it from an action standpoint throughout the classes, it loses its emphasis on actually being important because the action doesn't match the word,
Right.
right?
Interesting. That's a
And so for me, this is actually, part of the reason for the LTAP is because I realized, and I actually listened to their words, and I did take the time to get really good at my general listening and my assessment pieces and tune in my hands. And I actually did witness that that is where the magic happens. Like that is what gets good results. Is actually not the technique I was using, not the treatment tool, right? Not the intervention, but being in the right spot. It was and following the body. When I learned how to listen to the body and follow its lead and where to start treatment, that's when I could finally fly across the country, treat an athlete once and leave and not see him again for a week to 2 weeks and have and know and see his body hold on to whatever I did. That never happened before I learned how to like figure out where the body was
assess.
directing me.
Right.
And so that's what and when I was going to all the courses and people I would hear and people are like, "Oh, I don't really do general listening." And I'd be like, "Are you getting good results?" And they're like, "Nah, I mean, kind of." I'm like, "Do you know when to use the techniques?" And they're like, "Well, I kind of base it off of like the symptoms." And I'm like, how would you ever know to lift their liver if you don't have a way to like direct you to the liver?
Right.
Um, and so that's when I realized, like, man, it's not just people that don't have the brawl work that don't know how to find out where the body is leading them. It's everyone. And I'm like, if I could like if I could help people do that. And so what I was also at the same time, people were wanting to learn from me. And I was like, well, I can't teach them general listening because it's so difficult. General listening takes a long time of practice and
Mhm.
a whole journey, a whole nother podcast episode about trusting yourself and how to gain trust back into your own body and trusting what you feel. And so I'm like, how can I get to the same results orthopedically? And that's when I just started like looking for patterns within my orthopedic assessments and my and that's when I came up with the LTAP. And so that's like like going back to what you said, like how can this work for me when I haven't taken 20 Baral courses? And I'm like, because it's actually not about the 20 Baral classes. It's about the first couple that they teach.
Yeah.
They don't even emphasize it very well in the rest of the courses. And so that's like why I'm like, this is why it works, because as much as I love learning within their system, and I'll continue to take a bunch of their courses because I love why I take their courses now is because I love learning the anatomy.
Mhm.
When I take a course, it's not the technique. I might come away from that weekend with like 3 new techniques, but the growth of the anatomy in my brain and in my hands is exponentially improved. And so that's why I take the advanced courses, not for the techniques, but for the anatomy, because I also know that the techniques don't matter. In fact, this weekend when I demoed on somebody, it led me to their kidney. And I looked at Veronica Campbell, who's a PT that took my course. She's my mentor in the Brawl Institute. And I was like, I hope you're not disappointed. I'm actually not going to I'm not going to use a Baral technique for the kidney because I think cupping works better. And I did the dynamic cupping with the skin lift, and that was my treatment. And then later she's like, don't feel bad about that. She's like, if it works, like, she's like, if you found that it works just as well, she's like, why wouldn't you do that? Like, she's like, because again, like, I'm not trying to pass a techniques exam. I'm not
Right.
trying to impress the teachers that I know their techniques. I just want the results for my patient.
Right. And
the
it's that
nice thing
ego.
is
It's the lack of
it's the
ego
ego.
there, right?
Right. Right.
That is
So
the key.
I'm like, also, that just means I have a lot of more techniques to pick from. So if the cupping doesn't work for the kidney, then you better, well, no, I'm going to pick a different technique, and it might be a visceral technique, but it's like sometimes a general technique is just easier and more accessible for both me and the patient. And so why not start there? Like,
Yes.
why are we trying to make things so fucking
So
difficult?
hard. Yeah. It's like, stop. Just pick the
Yeah,
easy
just
thing.
pick the easy
Do
thing.
it.
So, anyways, that I think that's like an important thing. And even this weekend with people, I'm like, yeah, and also the reason why I like having other, like, a mix of practitioners in the course, because when your only tool is visceral manipulation, of course you would do visceral manipulation. If your only tool is movement, you're gonna have to figure out how to move these areas of the body. But what makes us a better clinician is to have more to pick from and to see it from a bigger 30,000 view foot. So 30,000 foot view. So it's like, even for me and you, like, how am I going to treat the obturator? You might pick an internal technique. I'm
Right.
going to pick an external technique. And you might have never even thought about that external technique.
Totally.
And so that means, okay, now you've just like opened your brain up to a new possibility. So, like, next time you do treatment on someone and an internal technique doesn't work, instead of being like, well, now what the heck am I supposed to do? You're like, well, I've got these 4 other external ones that, let's try these.
Totally. Yeah. I feel like, and for somebody too, like me, who preaches and whose, I hope, actions match what I talk about. But that's where it's like pelvic floor internal is very important. And also we have to treat
There's
outside
so
the
much else.
pelvis
Yeah.
if we're gonna really address the underlying why. Because, like I said from the beginning, people that have pelvic floor dysfunction as an output, or an organ dysfunction as an output of pelvic floor dysfunction, like, that has to come from somewhere, and there is a disruption in their nervous system, and there is a disruption in the way that they're processing safety, and there has to be, otherwise that wouldn't be the area that would had the problem.
Yeah.
And so it's like we have to look outside. And I know before we were talking, before we started pressing record, I know you were talking about, like, oh, sometimes you get questions from pelvic floor PTs saying, oh, well, I get how this relates to pain, but does this also relate to things like incontinence and prolapse? Did I get that right?
Yeah.
Yep.
Yeah. All
And
those
it's
things.
like, right. But if you think about the why behind somebody that might have incontinence, or the why behind somebody that might have prolapse, then you're going to be able to adapt these techniques, and really any technique external to the pelvis, to optimize the nervous system and the nerves that go to the pelvis and the nerves that go to the pelvic floor, right? So a good example of this too, and this was also when we so I've been teaching this as well. And then a really awesome physio from Australia who has a ton of courses on prolapse and incontinence talked about, the innervation of the bladder neck and the rhabdosphincter is the pudendal nerve. And so someone doesn't have to have pain to have dysfunction in their pudendal nerve. And that's where, everybody always thinks, oh, if you have pudendal nerve issues, then you automatically will have pudendal neuralgia and pain. And that's not
Yeah.
true.
Actually, not.
It's no, actually not at all. And so the pudendal nerve is something that I clear for every single person that has any problem with bowel, bladder, or sexual dysfunction, because it innervates the pelvic floor and it innervates a lot of the organs in that area, and it innervates the external vulvar skin. And so a part of it. And so it's like, but that nerve still has to have blood flow. It still has to have the lack of an inflammatory response going on there. It has to have good mobility to stretch and glide, right? And so that's where we can start to really expand our view of where we're treating both externally at the nervous system, the lymphatic system, but then also treating, let's say for pelvic floor people listening, like the Alcock's canal and at the ischial spine where it comes back in the pelvis for somebody that does have prolapse or incontinence, because you're enhancing the entire health of the system. And its nervous system response tools should go back up to the brain. And like, that's what we're also intervening on. It's not
Yeah.
just about the muscle. It's not just about the obturator internus. It is also about the health of the blood flow and the nervous system input and the peripheral nerve and the top down central nervous system autonomic response to that region. And it's all of it. And we have to intervene at all of it, or at least check off the boxes that it's cleared as okay, if we're going to expect the output down the chain to be improved, right?
Yeah.
And so that's where I really feel like the answer to that question is absolutely this way of thinking, this way of thinking, both, the whole organism is actually applicable to any symptom, right?
Right.
Including things like that you wouldn't think are related to that area.
Mhm. Yeah, and it's one of those things too that I'm always like, well, yeah, so that's like, so I teach. You start with the LTAP, you figure out where the body is protecting, and then you pause before you treat that area. Then you like ask the patient, like, what's going on? Like, what are we dealing with today? And so if their answer is low back pain, then you do all of your assessments that you would on low back pain, because you still want to gather like what's going on. Like, why do you have like let me get my best clinical judgment of why you have low back pain. But same thing if they're like coming in because they have incontinence or prolapse, then you're like, okay, well, I'm like, this is when you put on your pelvic floor physical therapist hat. Well, what would you normally evaluate with someone with incontinence or prolapse? Like me, not being a pelvic floor physical therapist, but like understanding sort of the mechanics of like where the anatomy is and the pressure. I'm like, okay, if somebody came in with me with prolapse, I'm assessing their SI area. I'm assessing I'm assessing their whole pelvis basically. I'm assessing their hip range of motion. I'm assessing their thoracic spine and their rib mobility. Like I'm actually probably also going to assess their ankle mobilities
Mhm.
to make sure they can shift their weight forward on their feet to get their pelvis in a good position
Yes.
from a pressurization standpoint, right? So it's like, yeah, I'm going to assess the nervous system. I want to see what kind of neural tension they have, because even though pudendal nerve is like, I love the pudendal nerve. I treat it all the time on my
Tons.
athletes,
Yes.
and right. And so even the pudendal nerve, it's so short and it's so close to the spine, but like in a general lower limb neural tension test, you'll still pick it up. Like you'll pick up if they've got general lower neural tension, they've got I'm like, it's probably not gliding very well either. Like
Yes.
it is what it right. So I use my neurodynamic tests to
Yes.
be like, is this peripheral or is this central? And all of this information becomes like the orthopedic stuff that I'm wanting to change. And then I'm like, okay, I've got my list of orthopedic stuff I'd like to change that I think is influencing your prolapse or your incontinence. And then I'm going to go back to where the LTAP directed me. And maybe the LTAP directed me to the central nervous system. So I treat whatever's going on in the cranium and then I retest all those things because I want to see what was that central nervous system tension? How was that influencing the mobility of their pelvis? How was that influencing the mobility of their thorax? How was it influencing the the general lower limb nerve tension, right?
Yeah.
Like, and then like, okay, now I've gotten this laundry list of orthopedic things that I know is involved in their prolapse. And now I've narrowed it from 25 things to 5 things. And
Mhm.
so it's like, now let's do the LTAP again. What's next? And it's like each layer I'm taking off a protection pattern and I'm actually narrowing in on the actual mechanical orthopedic thing that I think is related to their prolapse, that is like, is it truly need work on it, right? And
Right.
so it's
Right.
like, to me it's just doing it this way too is just like, ideally it should make things like prolapse and incontinence and things like a little easier to treat
Right.
because
Because and to your point, if we start to, and this is where I get all annoyed at this isolationist approach to pelvic floor strengthening a lot of the times, because it's like if someone came in with prolapse and all we're doing is strengthening the pelvic floor, as an isolationist approach, it's like it doesn't work that way. And even if it was gonna work in a small sense, it's still not functioning in the system like how we want. And so we have to take the broader view. I call it the adaptive strengthening approach, where we basically take all of the other things so that if we do end up having to strengthen at the end of the day, it's only up to the decreased demand that we were able to
Yeah.
create by treating the whole system. And
Yeah.
so that's where, yeah, I feel like our whole this is where I was like, in that course, I was like, yes, like we aligned and now we're best friends.
Yeah. Yes. And did we just become best friends? Yeah.
Totally.
I mean, it's so true. I mean, and that's the thing too, is like this is going like why I'm like so passionate about introducing a visceral and neural lens of view to practitioners, because it's like, yeah, okay, if you really truly think that a stronger pelvic floor is going to be the key, and you want to do all the pelvic floor exercises, well, exercise movement is still an output. So what are all the things that we can do to change the input to make the output come easier and make sure it sticks? Because if you're trying to get people to contract their pelvic floor through a concentric and cognitive experience of squeezing a muscle, then this is never going to work. This is like trying to tell somebody how to like do a like bicep curl, right? And
Right.
be like, okay, just
Get
this is how you're
stronger.
gonna get your bicep stronger by just holding that contraction and relaxing it, holding it and relaxing it. I'm like, no, like we know that an eccentric contraction is like just as important as the concentric, but we don't, our brain cognitively, like in order to like create an eccentric contraction of the pelvic floor, you actually have to tell them to contract the tricep, because that's the only way our brain understands muscle contractions, because this is our brain is not supposed to control muscle contractions.
Right, especially not those ones, right? Especially
Right.
the ones that are meant to function automatically, like, they're
Yeah.
controlling things like peeing, pooping, orgasm, like,
Yeah.
all of that. Like, if we had to think every time about each of those things,
We would be so slow.
we would be so slow. We would be annoyed. It wouldn't work well.
It wouldn't work.
It wouldn't
You
work.
couldn't think about it. Like, we literally couldn't think about anything else. Like,
Right.
this is just, yeah.
Right, because it'd be too much input, right.
Yeah.
Just like that's why we attenuate to, like, tags on our clothes, right?
Yeah.
It's like we're wired for that. So, yeah,
Yeah.
all of that is to say is
All
that
of the above.
we have to look at especially when we're looking at the pelvic floor, and I'm so passionate about this, is that you have to look at what its baseline normal optimal level of functioning is, and I'm telling you, it is not anything conscious, right? It's all
Not
automatic.
at
It's
all.
all reactive. It's all anticipatory postural, with a smidgen of voluntary contraction in the most crazy of circumstances. My bladder is about to burst, like, I cannot do,
Yeah.
I mean, obviously, but, like, that's so if we look at it through that lens, then we have to treat it through that lens as well. And we're not needing to introduce, like, don't make it harder than it needs to be. We don't need to introduce any, like, conscious stuff if we don't have to.
Right. Like nobody wants to like have to think before they move. Like,
No, it's just not
how
right.
about you just ensure that the nerves are communicating to that muscle great, and all the things it is protecting don't need to be protected, and
Totally.
then you have them just do a squat
Right,
and
and then it'll just work, and that for the
yeah,
same reason why, like, it was old school back in the day when we were in PT school and stuff, it was like, we were taught to brace the abdominals and, like, and to have them contract all the time during things. It's like, well, that was
yeah,
never a thing. It was never gonna work that way. It was all supposed
yeah,
to be automatic, and we need to train it to be automatic, just like, this is what the analogy I also use too, is that just like if somebody had a balance problem, we wouldn't give them only calf raises. We would be like,
right,
what do? You start to just train balance. You train the automaticity of
yeah,
getting a better balance, and you might have to control the environment a little bit to be able to adapt and make sure that they can be successful and stuff like that. But it's not always a strength problem. And so I
yeah,
feel like it's one of the biggest, like, pet peeves of mine in the pelvic floor world. It's like, it's not all about this damn fucking Kegel situation. And like practitioners sometimes fall into that thing too. And so I feel like that's why I love thinking about it from a hierarchy perspective, from a neuromuscular perspective, from a viscerosomatic perspective, from a somatovisceral perspective, and really making
Yeah.
sure that we're addressing each of those in the order that makes the most sense for the body, so that the patient can have the best outcome.
Yeah.
Love
That's
it.
great. It's funny, like whenever somebody is like, well, I went to pelvic floor physical therapy for this issue, and so I don't know if that's what I need. I'm like, well, what did they tell you to do? What did they do? And they're like, oh, well, they gave me like some Kegels. I was like, no,
Nope.
that wasn't the right person.
Yeah.
I'm like, don't give up on pelvic floor physical therapists.
Yes.
You just need a different one.
Yes. Totally.
Or you don't even need somebody as a pelvic floor physical therapist. You just need somebody that's like looking at the whole organism.
Yes. 1000%.
But so that's funny. All right. I know I don't want to like go crazy long. I know we could literally talk for hours.
Talk about this
So,
all day.
so please share where the people can find you, your podcast.
Yes. So I have a clinician-based podcast, similar to yours, the clinician-based, that is called Pelvic PT Rising Podcast. So I do that with my husband. You can find me on Instagram at Nicole Cozean DPT. I also, if you need a reference for your patients, I also have a patient-centered podcast called Finding Pelvic Sanity. And our clinic page on Instagram is at Pelvic Sanity. So those are the two places you can find me. If you're a clinician, though, for sure on Nicole Cozean DPT. And thank you, Anna, for having me. I really appreciate you having me on your podcast. I love our nerded out brains in this conversation.
Yeah. Yes, me too. Yes, I'll definitely link all those things in the show notes for everyone. Definitely check it out. I've listened to a couple. I'm not a big podcast listener,
No.
but I have listened to a couple of your episodes, and I'm like, oh my gosh, me! Like the whole time, I'm like, yes, I treat here too. Like yes.
Yes.
Like the one I did, I think it was on like some sort of like fascia related to the rectum, and I was like, oh my gosh, I treat this all the time with my athletes.
Yes.
So I was like, yeah, nerding out for sure.
Cool.
So it's a great podcast. Definitely. If you like my podcast, I'm sure you will like that podcast. So
cool.
Cool. Well, thank you for being here. I'm so grateful that we have connected and get to nerd out. And everybody who follows both of us is always like, when are you going to do a course together?
I know.
I'm sure one day. We just need to find the time to like.
One day, though.
But
reach out to us if you if that excites you. Make sure you DM Anna and or myself so we can with ideas.
Yes, with ideas. What would you want us to do?
Yes, what would you want to do?
How would it go?
Cool.
All right. Well, thank you very much, my dear. Thank you everyone for listening, and we'll see you next time.